So hi guys, let's start with orbital infections. Infections that can happen in the orbit, we need to begin with preceptor cellulitis. As you know, there is something known as the orbital septum. The orbital septum is somewhere here. This is like a membrane that sort of separates the eye into a preseptal and an orbital part. So if you have an infection before the septum, you will call it as a preseptal infection, whereas behind the septum would be called as an orbital infection or an orbital cellulitis, for example. So with that out of the way, look at preceptal cellulitis. So it is an infection of the fat in front of the septum. It is less serious and it is a lot more common than say orbital cellulitis. The culprits are staph and strep infections from around the eye. The diagnosis is done if you find swollen, firm, tender red orbit, but there is no chemosis and there is no proptosis. Pupil visual acuity and motility seem to be good, which indicates there is no compression. The treatment for a preceptor cellulitis would be pretty simple, including orbital oral antibiotics, augmentin TID, IV antibiotics if it is severe, and then you need to check the patient's tetanus status to rule out any other infections. Now, having a look at this diagram, this is how a typical presentation of a preceptor cellulitis would come to you. In this child, there is a left preceptor cellulitis which has been caused due to an infected eyelid aberration, possibly somewhere here. You could see a wound. Then on the axial CT, you can see there is an opacification seen in the left side of the orbital septum on the anterior part. So this is how you diagnose it. So one of the most common causes of unilateral proptosis in children is orbital cellulitis. And what do you think is the most common cause of bilateral proptosis and unilateral proptosis in adults? It is thyroid eye disease. So bacterial cellulitis would result from an infection that is behind the septum. So you won't call it as a post-septal cellulitis, you would just call it as a bacterial cellulitis. You have again staph as the culprits, but you also have Haemophilus influenza as the added culprit here. It is generally spreading from the ethmoid or the paranasal sinuses. This is very painful as opposed to the preceptor cellulitis, which was not painful. The bacterial cellulitis seems to be a lot more painful, especially on eye movement. And there is a recent history of a nasal sinusitis infection. And also it could be a upper respiratory tract infection. So be on the lookout for these sort of things. Also, since it's an infection, you will have an accompanying fever. It will be painful erythematous lids with edema that is warm to the touch, and then you'll have a painful ophthalmoplegia. These things will help you diagnose a bacterial cellulitis. So now looking at this, looks like a typical presentation of a bacterial cellulitis. The things you can see here is probably the patient will be talking to you about pain, and then you can see there's a painful erythematous reddish colored lid area in this part, and then you have some orbital fat that is also oozing from here, which is not mentioned. On an axial CT, you see both preseptal and orbital opacification. So this gives you a clue that the involvement is much deeper than a preceptor cellulitis. As you can see, on contrast, our preceptor cellulitis had only anterior opacification and there is no opacification in the orbital part or the deeper part of the eye. Now there's a lot of other reasons also where you could have an acutely inflamed orbit. It's not always orbital cellulitis as the go-to. So looking at them, it could be an infection like a bacterial or a fungal infection. You could have vascular lesions, which could be a CST or a CCF. Then it could be a neoplasia, and then it could be a thyroid eye disease of rapid onset, or a non-neoplastic inflammation such as Tolosa-Hunt syndrome, herpes simplex skin rash, sarcoidosis, vaginous granulomatosis, or a polyarthritis nodosa. So these are supposed to be the differential diagnosis that should be in your mind. So looking at the complications that are possible in a case of an orbital infection is always a neuropathy due to compression of the nerve. It could be a CRAO, CRVO, again due to irritation of the vascular system of the eye, which causes an embolus to be lodged into the central retinal artery or the central retinal vein. Then it could also undergo a cavernous sinus thrombosis if it involves the cavernous sinus. Then the infection or the pus could go into the brain and cause a brain abscess and subsequently cause a meningitis. You could ask for the patient's tetanus status as a part of your investigation, a complete blood count to rule out any infective status. Then you look for a blood culture to check if there's a active infection, active bacterial culprit, and then a CT brain to rule out any opacifications in the anterior or the involvement of the deeper part of the orbit. Also look at any infective sinuses to sort of get the origin of this infection. Then treatment would be, this is definitely a case for a hospital admission. This is one of the few ophthalmic emergencies that are there. What are some of the other ophthalmic emergencies that you know? Please comment with your answers. Delineating the orbital infection with a marker is always a good idea. It gives you a very good parameter as to judge the sort of progress the patient is having on subsequent follow-ups. Then we can proceed with an IV ceftazidime immediately along with an oral metronidazole as a precautionary measure. This is to be given till the fever subsides, and till 3 weeks you only give it orally. Monitor visual acuity, CV, brightness again to sort of rule out any compressive neuropathies, and always keep checking the pupillary reactions to gauge sort of the optic nerve, is it safe or is it at risk. Then you do a surgery, which it would be an incision and a drainage to drain the abscess, and if there is a severe optic nerve compression, then you can perform a canthotomy and a cantholysis, which you know is done by performing a decompressive procedure in the lateral canthus of the eye. You sort of take scissors and you just cut into the lateral part of the eye, and you sort of relieve the pressure in the back of the eye, which sort of decreases the pressure and makes it easier for the optic nerve to function and not cause any compressive neuropathies. So this is part of the essential residence procedures that you should know during your residency. Now looking at some more points regarding orbital infections. Patients with orbital cellulitis are typically febrile. For pseudotumor, this is uncommon, except in children. So orbital cellulitis typically accompanies with a febrile presentation, whereas pseudotumor does not. It's pseudotumor cerebri. A leukocytosis with a left shift is also more common in leukocellulitis. And then a sedimentation rate, the ESR may be elevated in either condition. So ESR is not really helpful as a diagnostic tool if you want to differentiate between orbital cellulitis and a pseudotumor, whereas a febrile presentation will help you diagnose it as being a orbital cellulitis. CT scan may show a non-specific retrobulbar infiltrate, but may have specific signs to one of the two disorders. A muscle enlargement and a subperiosteal abscess will help you diagnose it even further. Mucor, rhizopus and aspergillus can lead to a necrotizing orbital cellulitis, which is a more severe kind of a orbital cellulitis that has accompanying necrotic tissue, necrotizing of the orbital tissue along with the infection. The diagnosis in this case definitely consists of a biopsy, and under biopsy you will see a mucorrhizopus showing a branchage and a non-septate sort of hyphae that stains with a hemotoxin and eosin stain, and aspergillus will stain with a GMS stain, the gomorrhoea methylamine silver stain, and will show a branching septate hyphae. So the difference being a septate hyphae for the aspergillus and the non-septate hyphae for the mucor and rhizopus. And nivapotrecin B could be used for a treatment if it's a fungal necrotizing orbital cellulitis. A mucormycosis is generally seen only in the immunocompromised. So it's a rare disease to be seen if it's not an immunocompromised patient. So immunocompromised patients could be a diabetic patient to begin with, or it could be an AIDS patient suffering from HIV. So HIV positive patient. Chemotherapy post-transplant diabetes mellitus could also be some added conditions you need to keep the lookout for. Aspergillosis is probably more common in this population also, but it may be seen in otherwise healthy individuals also. So aspergillosis is something that is also seen in healthy and immunocompromised patients, whereas mucormycosis is predominantly seen in immunocompromised people. Orbital phycomycosis generally results from an invasion by the necrotizing fungal sinusitis. Black eschar in the nasal cavity is virtually diagnostic but is a late finding. Its absence does not exclude the diagnosis. So an orbital phycomycosis is caused due to the necrotizing fungal sinusitis and the invasion into the orbital tissues. So this will have a black eschar, which is a pathognomonic and a diagnostic finding, but the thing about it, it's a late finding and it does not exclude the diagnosis. So guys, that was this week's video. You did great job sticking till the end. Of course, the stamp for this video is the Egyptian Afro-Asian Ophthalmology Congress that was held in the year 1958, and along with that we have a beautiful Eye of Horus stamp that was the 15th Ophthalmology Congress held in Cairo, and this depicts the sacred Eye of Horus in Buto, and this was in the year 1937. Egypt has a rich history with ophthalmology, and you have a lot of ophthalmologists with very big names coming out from Egypt. So guys, as you know, ophthalmology stamps are kind of my thing, and I love ophthalmology stamps, and every time you stick till the end I shall speak to you briefly about the ophthalmology stamps. Guys, if you like this channel, please consider subscribing and sharing this channel amongst your friends, your medical students, medical graduates, undergraduates, postgraduates, the like of them. And if you like my content, please consider liking it, and please do leave a comment. I read all your comments, and all and any feedback is welcome. This is part of the revision series that I just wanted to do since I wanted to prepare for my exams. I hope these help you out too. Thank you.